Hello. So today we're going to talk about menopause. As I'm sure you're all fully aware, it's a really hot topic. So it's really important that we talk about it. I'm Hilary Maxwell. I'm a gynae-oncology clinical nurse specialist. I work in the NHS for the majority of the time. Women's health is my passion, and also cancer care in particular. So these are my disclosures. I receive an honorarium from the Healthy Employee. I'm Chair and CEO of Go Girls Charity. I'm a gynae-oncology clinical nurse specialist, just as I mentioned. I'm also Chair of the Nursing Forum for the British Gynecological Cancer Society. So that's a little bit about me. We won't dwell on that too much. That's something that you can read about in your own time, and I'll let you digest that yourself. But as I say, I'm a gynae-oncology clinical nurse specialist, and today we're presenting on behalf of the Healthy Employee. So first of all, I thought it would be really important for us to actually try and define what the menopause actually is. There's often quite a lot of confusion about this, particularly with the perimenopause. So menopause is a natural stage in life and part of the aging process. And of course, for some of our forebears, they may never have reached the menopause because often some of them would have died that much younger, certainly back in the Middle Ages, etc. So they would never have experienced what we now know as the phenomena of the menopause. So it marks the time when a woman's periods stop as her ovaries run out of eggs or stop producing eggs. So menopause can occur earlier than expected for some women. If it happens before the age of 40, it is known as premature menopause or premature ovarian insufficiency, POI. And in some women, this can occur as a result of some form of surgical or medical treatment, but sometimes this can actually run in families. So usually the perimenopause is probably the period before the menopause actually starts, and maybe anything from sort of about the age of 45. But ovarian function is gradually starting to decline really from your mid-30s. So how is the menopause diagnosed? Well, perimenopause based on vasomotor symptoms and irregular periods. Often women will notice they start to get increasing hot flushes, night sweats, just feeling their mood is altered, and their periods may become quite irregular. So menopause is in women who've not had a period for at least 12 months and are not using hormonal contraception, because in some cases, particularly if you're taking a combined HRT, that will also give you a period because of the progesterone. So menopause based on symptoms in women without a uterus. So there are some women who of course will have had a surgical menopause at various ages for a variety of health conditions. So how does the menopause make us feel? Well, as you can see from the little cartoon on the right, quite happy to stand in the middle of Alaska most of the time. So it's those vasomotor symptoms, for example, the hot flushes and sweats, that really seem to affect women quite badly. Musculoskeletal symptoms, for example, joint and muscle pain, effects on mood. I've often had women describe to me that they went from being very confident women in a workplace to sort of jangling wrecks. Urogenital symptoms, for example, vaginal dryness, sexual difficulties, for example, low sexual desire. And often all of these symptoms, and particularly the night sweat, often lead to very poor quality sleep. And as you can imagine, if you've not had good quality sleep, then your ability to function during the day is therefore that much more reduced. So how do we look at treating the menopause? Well, I mean, of course, you don't have to treat the menopause, it's a choice. So this is entirely up to yourselves. So hormonal replacement therapy, and we really would urge that you really shouldn't be taking that for more than about 5 years, and it must be safe in order for it to be prescribed, and it needs to be prescribed by a clinician. So they probably will want to go through a little bit of a checklist with you first before they feel that that is appropriate to you, and they will also look at risk factors, particularly in relation to family histories of breast cancer. There are some non-hormonal older drugs that can be quite helpful in relation to some of the vasomotor symptoms, for example, clonidine. You don't see that prescribed very much in practice these days. I'm not entirely sure of the reason why, but it may get more prescribed maybe at more specialist menopause centres. And then, of course, women often find quite helpful to have some cognitive behavioural therapy, particularly to cope with that altered mood and in effect that altered transition of life. This is a very, very significant stage of women's life, and particularly where women are working well into their 60s. This is you've got women in the workplace who bring a lot of wealth of experience and knowledge, and employers are very keen to obviously retain their employees and have a nice stable workforce. So it's really helpful to open up these dialogues and to ensure that women are as supported as best they possibly can, because it's a long transition and it's a very difficult transition, so we must be sensitive to it. So what exactly is HRT? Well, hormone replacement therapy, or HRT, is widely used to treat menopausal symptoms. So as you approach the menopause, the ovaries produce less and less of the hormone estrogen. And it's the estrogen that controls a woman's reproductive cycle, as well as controlling other functions, including bone density, which is really important, skin temperature, and keeping the vagina moist. This reduction in estrogen causes most symptoms associated with the menopause, including hot flushes, night sweats, vaginal dryness, loss of sex drive, stress incontinence, so that sort of leaking of urine when you cough or sneeze, bone thinning, which can lead to osteoporosis, which is really important. So the aim of HRT, literally as its name suggests, hormone replacement therapy, is to top up the body's natural estrogen. And estrogen also stimulates the lining of the womb. So it's really important, if you've still got a uterus, womb, you will need progesterone. So you will need a combined HRT in order to protect yourself from endometrial cancers, which would put you at a higher risk. We'll talk about risks a little bit later. So here we come, HRT and risks, just as I said it. So the risk of VTE associated with HRT is greater for oral than transdermal preparations. So that's a clot, basically, in effect, a venous thrombose. So embolism. So that's a VTE. So it's a clot. So we need to be very mindful of that. And usually where people most commonly experience clots will be in the lower calf. Often if you notice pain, it's red hot swelling. So always be mindful of those things. It does not increase cardiovascular disease risk when started in women aged under 60. And taking HRT either orally or transdermally is not associated with an increased risk of developing type 2 diabetes. HRT with estrogen progesterone can be associated with an increase in the risk of breast cancer. And this is why it's commonly stated you really shouldn't be taking HRT for any longer than 5 years. After 5 years, your risk does start to increase. So that is something to be mindful of. And of course, everybody would want to try and do their very best to avoid increasing their risk of a breast cancer. The likelihood of HRT affecting the risk of dementia is unknown at the moment. We don't have sufficient evidence on that. And there's limited evidence suggesting that HRT may improve muscle mass and strength. So it's really, really important to maintain your physical well-being really throughout your life, so that you not only are cardiovascularly strong, but you also have strengthening of your muscles and joints, really, to protect, keep those muscles strong, to keep the joints stable. So it'd be interesting to know what you personally think about HRT, bearing in mind probably lots of the things that we read in the media against what we're talking about today. And then some women will choose to have complementary therapies. Now, they may choose to have that alongside, or they may just choose to not have any HRT and to go with the flow and perhaps use complementary therapies to help support them. So the alternatives to HRT are really broadly classified into herbal medicines, a practice based on the use of plants or plant extracts to relieve symptoms, for example, evening primrose oil or Sir John's wort. Alternative medicine, a range of therapies that we talked about instead of conventional medicine, such as acupressure, acupuncture and homeopathy, complementary therapy, and non-hormonal medical treatments, such as antidepressants, which may be prescribed by your GP. These are entirely personal choices that you can choose to make. One thing, just a sort of slight note of caution, you do need to be quite careful if you're taking a range of complementary medicines, particularly on the herbal medicines, because they can interfere with conventional medications. And certainly I've seen some women that I care for with gynecological malignancies who take a range of herbal medications, and we know that they can impact upon some of those treatments. So we've had to have those checked by a pharmacist. So menopause and work, how to cope. Why does this matter? Well, we've touched on this briefly already. So coping with menopausal symptoms at work can be tough, and some women are understandably reluctant or even afraid to talk to their employer about it. But with around 3.5 million women aged between 15 and 65 years currently in employment in the UK, women actually now represent nearly half of the UK labour force. And that surely makes menopause mainstream and as important as any other occupational health issue. It has even been described as an equality issue. Whether that's going to go that far, I have my doubts. There's been some mooting around it. But I'm not sure whether they feel that may open the floodgates. It'd be interesting to again see what your thoughts on it. But without a doubt, it is going to impact the workforce quite considerably, and a significant number of the workforce, this is when women have often raised children, are coming back into the workforce, really forging ahead with their careers, and then all of a sudden they sort of feel that they're reaching the buffers and then may get looked over and don't feel as youthful and as they did before. They may be a little bit more forgetful and things like that. But it's working with it. To me, it's always about working with. This is a natural stage of women's life, and women in the workplace at this stage of their life can provide a lot of enrichment and as I say, often contain a lot of knowledge and experience that are extremely valuable to an employer. So why can talking about the menopause be hard? And I suppose, like a lot of issues in women's health, this is something that we are going to have to think about going forward in terms of overcoming some of the stigma and some of the embarrassment that often surrounds women's health. And if we can't do that as women, it will be that much harder for other people to do that as well. So many women actually find that they're little prepared for the onset of the menopause. They know it's coming, but actually, like most things, when it sort of suddenly arrives, they find it very difficult, and they're often very overwhelmed with symptoms. Now, there are very few women that sail through the menopause. You'll always hear a story, of course, of somebody who, I didn't have any symptoms, don't know what you're making all the big fuss about, etc. But for most women, this is very, very real and a very real lived experience. So they often tend not to disclose their symptoms to their manager. They kind of keep it all a little bit under wraps and find it quite difficult to talk about. So the majority of women definitely feel that they need further advice and support. And workplaces and working practices have probably not traditionally been designed with menopausal women in mind. Heavy and painful periods, hot flushes, mood swings, fatigue and poor concentration, they can all pose significant and embarrassing problems for some women, and that can result in lower confidence. I mean, how many of us have sat in a meeting and our mind's gone completely and utterly blank, we just can't get any further, and it's gone completely and utterly out of our heads. And it's not because we're being daft, it's just a physical phenomena. And we need people to bend to that and say, well, we'll come back to you when that's come back into your head, and perhaps be a little bit light about it, rather than, because the more stress you get, the worse those symptoms actually do become. So women have also stated they feel uncomfortable disclosing their symptoms and problems to managers, particularly if they're young and male. And I think that's understandable, because how do you get somebody who's never ever going to go through a period or a menopause or anything like that? How are you actually going to get them to fully understand what does this really mean? You can't really step into somebody else's shoes and experience that. So when women often have to take time off work to deal with their symptoms, particularly if they've got, period flooding in that perimenopausal stage, they may not disclose the real reasons for their absence. But I think we have a responsibility for ourselves as women to be a little bit braver and to talk about things. And for our managers, particularly if they're male, and this is not to pinpoint them because in any shape or form, because it equally may apply to some women who are younger, who've not been through these experiences, that we need them to be kind and sensitive to us and to work with us. That's the most important thing. It's about working with. So some women say they have to work extremely hard to overcome their perceived shortcomings due to their menopause. And I do see that quite a lot. They're trying to cover up all the time, oh, I think I'm slipping here, I may just stay a little bit extra. But that's not necessarily the answer. Sometimes it's best just to take a little walk away from your desk. Let's go outside, just grab a bit of fresh air, and then regroup, and then find out where you can pick up where you left off. And often just having that little bit of brain space will help reduce some of that brain fog. Others consider working part-time, and that's often because the fatigue is so bad, because you're not sleeping very well, and despite the concern about the impact on their career. And some sadly even think about leaving employment altogether. So it is very, very concerning. And it is really, really important that both employers and employees work together to look at how they can best manage menopause. Many companies and organisations will now have a menopause policy, but that's a two-dimensional document, and it's really, really important to make sure we lift this subject off the page, away from two-dimensional, and not thinking, gosh, we've just ticked the box, we've got a menopause policy, isn't that marvellous? Because this is a real lived experience on a day-to-day basis, affecting many people in employment. So how easy do you find it to talk about the menopause? So there's a little quote here from Sharon Edwards. I'll let you read that quietly in your own time. But as you can see, she very much emphasises that this topic has been shrouded in secrecy for too long and resigned to whispered conversations between men, or jokes about hot flushes, if even discussed at all. So even women themselves, I'm afraid, are sort of, party to the tittering and the in the corner and, oh gosh, sweating like a pig today, and making light of something that actually is a very, very real concern, rather than us talking about it seriously. And interestingly, when you look at the history of women in medicine and women's health throughout the various generations, even stemming back to the 1850s, women's health has not really been spoken about. It's not been seen as dignified. It's often been seen as a bit dirty. We don't talk about periods. And so therefore, inevitably, you get those whispered corner conversations. And as I said, we have to recognise a lot of women are now working well into their 50s and to their 60s. Retirement age is getting further and further distant to us all, to the point that we'll probably feel we're never ever going to retire. And I'm sure that crosses the minds of the younger generation particularly. So they really will be living with these symptoms for that much longer before they can possibly think about retirement, but they still have very, very valuable contributions to make to the workplace. And I think it's really important that you remember that you have a valuable contribution to make to the workplace. So how can employers offer support? Well, we talked about a menopause policy, but it's really important to obviously invite the women to contribute to this. We don't want it just stuck in a standalone policy for HR to do. And it probably is quite important to involve somebody clinical, actually, that might be quite a tall order for some organisations, but I think actually it is very, very important to involve somebody clinical who's got that background knowledge and hasn't just sort of researched it off the web, because obviously like any clinical subject, there's a lot more to it than we can discuss today, unfortunately. Think about flexible working now. Most organisations do have a flexible working policy, but often there has always been that caveat, hasn't it, for the employer to go, doesn't suit service needs, can't possibly think about that. But I think we have a sense of responsibility to again lift these policies off the page and think, well, actually, how can we make it work? We all faced that during COVID, and we did get to make things work. And in fact, often people working at home can be extremely productive because they don't have lots of interruptions. You don't lose a lot of time with that knitter-natter in corridors, another 10 minutes here, another 15 minutes there. Oh, should we meet for a coffee? So actually people can be very, very productive. And so, sometimes people are condensing their 5 days into 4 because they are so productive. Think about the environment. Provide fans, air conditioning and shower facilities. These hot sweats can be very, very overcoming, and people can feel very, very self-conscious about it. And so they may need changing facilities. They may need to bring an additional set of clothing. They just may need that little bit of time out just to freshen up. And we've got to start to see these things as normal for these people in the workplace. Recognising stress. This can worsen menopausal symptoms, and I think really probably stress, with our release of cortisol in our fight and flight is often, something that worsens a lot of elements, of course. Recognise cogitation may definitely be affected. So I felt I did have a bit of cogitation then. So it's really important to offer patience and support. Okay, so we don't want to be kind of, why are you not spitting that out? Why haven't you you've just got to allow people, because if you continue to push them under that stress, then they won't be able to cogitate in the same way and be able to collect their thoughts. One size does not fit all. Menopause can affect us all in different ways. So support, be flexible, and let's not forget, it's really, really important. Let's be kind to ourselves, and let's be kind to each other, and just try and have a care. So the Menopause at Work, a guide for people professionals from CIPD, says a standalone policy provides clarity for managers and employees. For example, setting out key responsibilities and signposting to sources of support. Developing a policy provides an opportunity to engage with employees on the issue and shows the workforce it regards the menopause as a serious work-related health issue. That's fine, and that's all very well and good, but we must lift these policies off the page and enact them in practice. And those on the left are some of the thoughts that we can think about as employers and managers to help support our workforce. I mean, for all of us who have managed people, there's always, the odd person, but the majority of people are coming to work to do their very best for their employer. They often like their jobs and they want to achieve the very best. But we can't stop the natural phenomena of the menopause, so we have to go with it, both ourselves as women who may be going through it, but also those who are observing it as well, and that inevitably will be the employer. So what are the red flags and why do they matter? So postmenopausal bleeding is not normal. This is a really, really important point. This can be an early sign of endometrial cancer, and postmenopausal bleeding can be pink, brownish, red, and it can be actually only very, very small amounts as well, but it must be postmenopausal, so you've got to be that 12 months without a period. So unusual discharge, pelvic pain, get it checked. Now, if you're on HRT, you must stop this 6 weeks before a referral, and you're probably going to go, oh, no, I can't. Why have I got to do that? The difficulty is many women who've still got a uterus, as I say, who are on that combined estrogen progesterone HRT may still have elements of a period as well. So you're not getting necessarily a fair assessment. Is this true postmenopausal bleeding, or is it related to a combined estrogen progesterone HRT? So it is really important to stop that. Now, postmenopausal bleeding is a red flag, and it's really important you contact your GP straight away if you notice even the smallest amount of postmenopausal bleeding. I've had some women who've come to see me with endometrial cancer who said, well, it felt like nothing, and you know, I didn't think I was going to do anything about it, but I'm jolly glad that I did. So I know it can be hard contacting the GPs, but it is a red flag symptom, and every GP recognises this, and all women with a postmenopausal bleed will be referred in on what's called a 2-week wait or a fast track referral. But can I assure you, in the majority of cases, this will not be a cancer. But endometrial cancer is on the rise, and that's principally because we have got an obesity epidemic, so it's very much affected by weight. And we are also, since COVID, seeing some later stage disease. Now, also endometrial cancer is one of those cancers that is extremely well treated, with very, very high success rate, because it gives the sign and it's often confined to the uterus. So endometrial cancer is cancer of the lining of the womb. So please don't delay on a postmenopausal bleeding, in the same way as I hope many of you, if you'd found a breast lump, you would also instantly make an appointment to see your GP to get an assessment, and for the GP to determine whether it was a 2-week wait referral. So where can you go to for further help and advice? Well, there's many organisations out there. Women's Health Concern, the Daisy Network, Menopause Matters. You know, those are certainly some good organisations that can provide lots more information and guidance to you. So thank you for taking the time to be here today. I know that we are going to have a question and answer session, which I will be joining into. So now that you've had an opportunity to listen to the presentation and perhaps think about some of the things that we said, I'll certainly do my very best to help answer any questions that we possibly can. And thank you very much for taking the time out of your busy days to be here and to listen. I hope you enjoy the rest of your day, and thank you very much indeed. I'm Hilary Maxwell, Gynae Oncology Clinical Nurse Specialist for the Healthy Employee today. Thank you.